Good day, everyone. Now, we will discuss coagulation and bleeding disorder. Before we will proceed, let's have first a picture of our platelet. So this one is our resting platelet, and this is the activated platelet. In the absence of injury, the resting platelets can circulate freely because there is a balance of chemical signals which indicates that the vascular system is not damaged. When receptors on the surface of the adhering platelets are activated by collagen, or in situations where there is an injury, it will cause a morphologic change in the platelet, and this will cause a release of platelet granules containing chemical mediators such as adenosine diphosphate or ADP, thromboxane A2, serotonin, platelet activation factor, and thrombin. So now let's define the term hemostasis. Hemostasis is a finely regulated dynamic process of maintaining fluidity of the blood, repairing vascular injury, and limiting blood loss while avoiding vessel occlusion or thrombosis, and inadequate perfusion of vital organs. The mechanism of blood coagulation. So the vascular endothelial cell layer lining of the blood vessels has an anticoagulant phenotype, and circulating blood platelets and clotting factors do not normally adhere to it to an appreciable extent. However, in case of vascular injury, the endothelial cell layer will rapidly undergo a series of changes, resulting in a more procoagulant phenotype. Thus, thromboxane A2, adenosine diphosphate, and serotonin will be released. Thromboxane A2 is a platelet activator and a potent vasoconstrictor synthesized from the arachidonic acid within platelets. The adenosine diphosphate is a powerful inducer of platelet aggregation. Serotonin are products secreted from platelet granules, which stimulates aggregation and vasoconstriction. Activation of platelets result in conformational change, as what I've mentioned earlier. So when platelets are activated, it will cause conformational change in the 2B or 3A receptor, enabling it to bind to fibrinogen, which cross-links adjacent platelets, resulting in aggregation and formation of platelet plug. Simultaneously, or at the same time, the coagulation system cascade is activated, resulting in thrombin generation and a fibrin clot which stabilizes the platelet plug. Blood coagulation cascade. So this blood coagulation cascade will also happen at the same time when platelets are activated. Coagulation in this is due to the transformation of soluble fibrinogen into insoluble fibrin by the enzyme thrombin. Thrombin is an enzyme that proteolytically cleaves small peptides from fibrinogen, allowing fibrinogen to polymerize and form a fibrin clot. Antithrombin is an endogenous anticoagulant and a member of the serine protease inhibitor serpin family, wherein it inactivates the serine proteases 2A or the thrombin and other factors such as 9A, 10A, 11A, and 12A. Protein C and protein S are endogenous anticoagulants which will also attenuate the blood clotting cascade by proteolysis of the two cofactors 5A and 8A. What do you mean by the term fibrinolysis? So, fibrinolysis is a process of fibrin digestion by the fibrin-specific protease, which is the plasmin. In response to injury, the endothelial cells synthesize and release tissue plasminogen activator or the TPA, which is responsible for the conversion of plasminogen to plasmin. Increased fibrinolysis is effective therapy for thrombotic disease, while decreased fibrinolysis protects clots from lysis and reduces the bleeding of hemostatic failure. Tissue plasminogen activator or the TPA, urokinase, and streptokinase all activate the fibrinolytic system. The aminocaproic acid is a clinically useful inhibitor of fibrinolysis, while heparin and oral anticoagulant drugs do not affect the fibrinolytic mechanism. Drugs used in clotting and bleeding disorders fall into two major groups. First groups are drugs that are used to decrease clotting or dissolve clots already present in patients at risk of vascular occlusion, and the second drugs are those that are used to increase clotting in patients with clotting deficiencies. So the first drug that we have here for clotting are the anticoagulants. These drugs are further classified into three major types. First are the heparin and other related products, which must be used parenterally. Second are the orally active coumarin derivatives, such as the warfarin. And lastly are the direct thrombin and factor X inhibitors, which are used parenterally or orally. Heparin, which is a strongly acidic substance, is a heterogeneous mixture of sulfated mucopolysaccharides. Its biologic activity is dependent upon the endogenous anticoagulant, which is the antithrombin. So therefore, the mechanism of action of heparin is AT3 or antithrombin 3 dependent. Antithrombin inhibits clotting factor proteases, especially the 2A, which is the thrombin, and other factors such as 9A and 10A. High molecular weight fractions of heparin are with high affinity for antithrombin markedly inhibit blood coagulation by inhibiting all three factors, especially the thrombin and the factor XA or 10. Low molecular weight fractions of heparin are effective in several thromboembolic conditions. So low molecular weight heparin has less effect on thrombin than the high molecular weight heparin. The unfractionated heparin, or the UFH, has a molecular weight range of 5,000 to 30,000 Da. Compared with high molecular weight heparin, the low molecular weight heparin has greater bioavailability and longer durations of action, thus doses can be given less frequently, usually once or twice a day. They are given subcutaneously. So examples of low molecular weight heparin are enoxaparin, dalteparin, and tinzaparin. Because heparin acts on performed blood components, it will provide anticoagulation immediately after administration. The action of heparin is monitored with activated partial thromboplastin time or the APTT laboratory test. Low molecular weight heparins and fondaparinux, like unfractionated heparin, will bind to antithrombin 3. So, what is fondaparinux? Fondaparinux is a small synthetic drug that contains a biologically active pentasaccharide present in both unfractionated and low molecular weight heparins. It is administered subcutaneously, which has a once daily dosing. It has a long half-life of 15 hours. Fondaparinux is indicated for the prevention and treatment of venous thromboembolism. It does not appear to cross-react with pathologic HIT antibodies in most individuals. Heparin is used when the anticoagulation is needed immediately. This is for the treatment of DVT or deep vein thrombosis, pulmonary embolism, and acute myocardial infarction. Heparin is also used in combination with thrombolytics for revascularization and in combination with glycoprotein 2B3A inhibitors during angioplasty and placement of coronary stents. Heparin is also the drug of choice when anticoagulation must be used in pregnancy. For the toxic effects of heparin, heparin will increase bleeding, which may result in hemorrhagic stroke. So that's the major adverse effect of heparin. So elderly women and patients with renal failure are more prone to hemorrhage. So the increased bleeding caused by heparin can be reversed by the protamine sulfate. Unfractionated heparin causes moderate transient thrombocytopenia and severe thrombocytopenia and thrombosis, which is the heparin-induced thrombocytopenia or HIT. Prolonged use of unfractionated heparin is associated with osteoporosis. Heparin can also increase loss of hair and reversible alopecia. Next, we are done with the indirect thrombin inhibitor, which are heparin and related products. Now we will move on to the orally active coumarin derivatives like the warfarin. Warfarin is a congener of the coumarol. So the name warfarin comes from Wisconsin Research Foundation with arin. Warfarin is initially used as a rodenticides. Warfarin and other coumarin anticoagulants are small lipid-soluble molecules that are readily absorbed after oral administration. So the bioavailability of warfarins are 100%. It is highly bound to plasma proteins, and its elimination depends on the metabolism of cytochrome P450 enzymes.
Allow me to correct myself. This is not warfarin and other common anticoagulants, but um, the correct is warfarin and other coumarin anticoagulants. It's not coumadin but coumarin because coumadin is a brand name of warfarin. So I apologize for that.
Mechanism of action of warfarin: they block the gamma carboxylation of several glutamate residues in prothrombin and factors 7, 9, and 10, and the protein C and protein S. So this blockade will result in incomplete coagulation factor molecules that are biologically inactive. The protein carboxylation reaction is coupled to oxidation of vitamin K. So another mechanism of action of warfarin, they inhibit vitamin K epoxide reductase, which then converts vitamin K epoxide to reduced vitamin K. So the action of warfarin can be reversed with vitamin K, but recovery requires a synthesis of new normal clotting factors. The effect of warfarin is monitored by prothrombin time or PT test. So for the reversal of warfarin, there's a more rapid reversal that can be achieved by transfusion of fresh or frozen plasma that contains normal clotting factors. Clinical applications of warfarin. Warfarin is used for chronic anticoagulation except in pregnant women. Bleeding is the most important adverse effect that has been seen with warfarin. It can be reversed by stopping the drug and administering oral parenteral vitamin K, phytonadione, fresh frozen plasma, prothrombin complex concentrates, and recombinant factor 7A. In the early therapy, a period of hypercoagulability and cutaneous necrosis occurs contraindicated during pregnancy. It caused a serious birth defect and characterized by abnormal bone formation. So there's a bone defects and hemorrhage in developing fetus. Because warfarin has a narrow therapeutic window, it is a major concern during drug interactions. Now we're done with heparin and other related products, orally active coumarin derivatives, such as warfarin, and now let's proceed with the direct thrombin and factor X inhibitor. Direct thrombin inhibitors. Direct thrombin inhibitors are based on proteins made by the Hirudo medicinalis, which are the medicinal leech. Leeches have been used for bloodletting since the age of Hippocrates. More recently, surgeons have used medicinal leeches, the Hirudo medicinalis, to prevent thrombosis in fine vessels of reattached digits. So Hirodin is a specific irreversible thrombin inhibitor from leech saliva that for a time was available in recombinant form, which is the leperodin, while the cerodin and bivalirudin are modified forms of hirodin. Leperodin is excreted in the kidney and should be used with great caution in patients with renal insufficiency as no antidote exists for this. However, leperodin production was discontinued due to life-threatening anaphylactic reaction. Bivalirudin is another bivalent inhibitor of thrombin, which is administered intravenously with a rapid onset and offset of action. Another is the argatroban, which is a small molecule with short half-life. This is FDA approved for use in patients with HIT with or without thrombosis and coronary angioplasty in patients with HIT. So all this, the lipyrodin, this cerodin, bivalirudin, argatroban are administered parenterally. The bigatran, this is the only direct thrombin inhibitor that has a oral route which is approved by the FDA. The direct thrombin inhibitors exert their anticoagulant effect by directly binding to the active site of thrombin, thereby inhibiting thrombin's downstream effects. Protein analogs of leperodin will bind simultaneously to the active site of thrombin and to thrombin substrates. Unlike heparins, these drugs inhibit both the soluble thrombin and the thrombin enmeshed with developing clots. Argatroban will bind solely to the thrombin active site. Bivalirudin also inhibits platelet activation. Direct thrombin inhibitors are used as alternative to heparin in heparin-induced thrombocytopenia or in HIT. Bivalirudin is used in combination with aspirin during percutaneous coronary angioplasty, while the bigatron is approved for prevention of stroke and systemic embolism in non-valvular atrial fibrillation, treatment of VT following 5 to 7 days of initial heparin or low molecular weight heparin therapy. This is also used for reduction of risk of recurrent VTE and VTE prophylaxis following hip or knee replacement surgery. Like other anticoagulants, the direct thrombin inhibitors will cause bleeding. There is no reversal agent that exists for this, and prolonged infusion of liperidine, which can induce antibodies that form a complex with liperidine and prolong its action, and it can induce anaphylactic reactions. Oral direct factor XA inhibitors, including rivaroxaban, apexaban, and indoxaban. So these drugs have a rapid onset of action and shorter half-lives than warfarin. It is given as fixed oral doses and will not require monitoring. The oral direct factors XA inhibitors will undergo CYP450 dependent and CYP450 independent elimination. Rivaroxaban has high oral bioavailability when taken with food. Apexaban has oral bioavailability of 50% and prolonged absorption. Indoxaban has 62% oral bioavailability. So these direct oral factor 10A inhibitors will directly bind to and inhibit both free factor 10A and factor 10A bound in clotting complex. The clinical application of these drugs, rivaroxaban is indicated for prevention of venous thromboembolism following hip or knee surgery for prevention of stroke in patients with atrial fibrillation. Apexaban and indoxaban is indicated for the prevention of stroke in non-valvular atrial fibrillation. For the toxic effects of these drugs, like other anticoagulants, the factor 10A inhibitors can cause bleeding, and there is no reversal agent that exists for this. Now let's move on to fibrinolytic drugs. Fibrinolytic drugs, so they rapidly lyse thrombi by catalyzing the formation of the serine protease plasmin from its precursor zymogen and plasminogen. They create a generalized lytic state when administered intravenously. In fact, fibrinolytic drugs are used in either of these forms. So we have the streptokinase, urokinase, and the TPase or the tissue plasminogen activators. This streptokinase, these are protein that is synthesized by streptococci that combines with the proactivator plasminogen. So this enzymatic complex is used to catalyze conversion of inactive plasminogen to active plasmin. Next is the urokinase, another human enzyme that is synthesized by the kidney and directly converts plasminogen to active plasmin. Another is the TCase or TPase or the tissue plasminogen activators. They are also an enzyme that endogenously activate plasminogen that is bound to fibrin. Recombinant human TPA is manufactured as atiplase. Retiplase is also a recombinant human TPA from which several amino acid sequences have been deleted. Tenecteplase, another mutant form of TPA that has a longer half-life, and it can be given as intravenous bolus. These retiplase and tenecplase are as effective as atiplase and have simpler dosing schemes because of their long half-lives. So dosing for retiplase and tenecteplase is simpler than atiplase. Next is the classic clinical application or pharmacologic effect. So fibrinolytic drugs are given intravenously. It is indicated for pulmonary embolism with hemodynamic instability, severe deep venous thrombosis from which the such as the superior vena cava syndrome, ascending thrombophlebitis of the iliofemoral vein, and severe lower extremity edema. Aside from intravenous, fibrinolytic drugs are also given intra-arterially for peripheral vascular disease. Toxic effects of fibrinolytic drugs include bleeding or the cerebral hemorrhage. Antiplatelet drugs. So we have here platelet aggregation. Platelet aggregation is contribute to clotting process and is especially important in clots that form in the arterial circulation. Platelet aggregation has a role in pathologic coronary and cerebral artery occlusion. Platelet aggregation is also triggered by a variety of endogenous mediators such as the prostaglandin, thromboxane, adenosine diphosphate, thrombin, and fibrin. Three categories that regulate platelet function. First, we have first category is that agents generated outside the platelet that interact with the platelet membrane receptors. That includes the catecholamines, collagen, thrombin, and prostacyclin. The second category for antiplatelet drugs, we have the agents generated within the platelet that interact with membrane receptors. That includes the DP or dopamine, prostaglandin D2, prostaglandin E2, and serotonin. Third category of antiplatelet drugs are the agents that is generated within the platelet that act within the platelet. That includes prostaglandin, endoperoxide, and thromboxane A2, the cyclic nucleotide CAMP, and CGMP, and calcium ion. So these are the examples of antiplatelet drugs. Aspirin is used in the inhibition of prostaglandin synthesis. Clopidogrel, prasugrel, and ticlopidine, these are for inhibition of ADP-induced platelet aggregation. Abciximab, tirofiban, and eftifibatide. So these are drugs that block glycoprotein 2B and or 3A. Next is the dipyridamole and cilostazole. These are other additional antiplatelet. Aspirin, pharmacokinetic properties and mechanism of action. Aspirin inhibits the synthesis of thromboxane A2 by irreversible acetylation of the enzyme cyclooxygenase. Thromboxane A2, this is an arachidone product that causes platelet to change shape, release their granules, and aggregate. So this is the one that is inhibited by aspirin. Next, because platelet lack the machinery of for synthesis of new protein, inhibition by aspirin persists for several days until new platelets are formed. So aspirin lasts for several days. The effects of aspirin last for several days until new platelets are formed. Unlike other NSAIDs and other salicylates, they only have a shorter duration of inhibitory action, and their effects are reversible and not irreversible like aspirin. This is due to the fact that they inhibit they did not acetylate cyclooxygenase unlike aspirin. So they only have shorter duration of action, and they shorter duration of action, and is reversible. Clinical application or pharmacologic effects. So aspirin is used to prevent further infarcts in persons who have had one or more myocardial infarction. It is used in reducing the incidence of first infarcts, and it is used extensively to prevent transient ischemic attacks or the ischemic stroke and other thrombotic events. Aspirin is also used for primary prophylaxis, but it is associated with bleeding risk. For aspirin is also used for secondary prevention of vascular events among patients with a history of vascular events. Yes. Next is the toxic effects that is associated with aspirin. Aspirin causes GI and CNS effects. It significantly enhances the effects of other antiplatelets. Another antiplatelet drugs is the thienopyridines, the ticlopidine, clopidogrel, and the prasugrel. As what I've said earlier, these are drugs that inhibit the ADP-induced platelet aggregation. We call that as the thienopyridines. Ticlopidine, clopidogrel, and prasugrel reduce platelet aggregation by inhibiting the ADP pathway of platelets. These are converted in the liver to active metabolites that irreversibly inhibit the platelet ADP receptor. So they irreversibly inhibit, like aspirin, irreversible inhibition, but no effect on prostaglandin metabolism, because unlike aspirin, because aspirin inhibit prostaglandin. Thienopyridine, ticlopidine, clopidogrel, and prasugrel clinical application or pharmacologic effects. So we have this. Clopidogrel and ticlopidine are effective in preventing transient ischemic attacks and ischemic stroke, especially in patients who cannot tolerate aspirin. Prasugrel, that is similar to clopidogrel, is also approved for patients with acute coronary syndrome. Clopidogrel is used to prevent thrombosis in patients who have received coronary artery stent. Clopidogrel, on the other hand, is also used for patients with unstable angina or non-ST elevation acute myocardial infarction, or what we call as NSTEMI, in combination with aspirin. Clopidogrel is also used for patients with ST elevation myocardial infarction, or STEMI, and it is also used with patients who have recent myocardial infarction, stroke, or established peripheral arterial disease. Additional drugs for this is the ticagrelor and the cangrelor. Ticagrelor is a newer type of ADP inhibitor, or the cyclopentyl triazolopyrimidine. It is approved for oral use in combination with aspirin in patients with acute coronary syndromes. Cangrelor is a parenteral P2Y12 inhibitor. It is also used for approved for IV use in coronary interventions in patients without previous ADP P2Y12 inhibitory therapy. Toxic effects associated with thienopyridines. Ticlopidine is rarely used because it causes bleeding in up to 5% of patients. It is associated also with severe neutropenia in 1%, about 1% of patients, and very rarely thrombocytopenic purpura, or the TTP, nausea, dyspepsia, diarrhea, and leukopenia. Clopidogrel is less hematotoxic. So, clopidogrel has fewer adverse effects than ticlopidine and is rarely associated with neutropenia. So, clopidogrel is the one that is frequently preferred over ticlopidine. Another toxic effects is the major and minor bleeding risk increased with the use of prasugrel. Next is the glycoprotein drugs that inhibit the glycoprotein 2B or 3A receptors. We have the what we called as the Glanzmann's thrombocythemia. This is a disorder So person lacking these receptors, the GP2B or 3A receptors, so they have these disorders. So this is a kind of a bleeding disorder. When we say glycoprotein 2B or 3A receptors, this is a receptor that functions mainly for fibrinogen and vitronectin. Pharmacokinetic properties and mechanism of action, we have activation of this receptor complex is the final common pathway for platelet aggregation. Abciximab is a monoclonal antibody that reversibly inhibits the binding of fibrin and other ligands to the platelet glycoprotein 2B or 3A receptor. Next is, abciximab is the first agent approved for this class of drugs. Next is the eptifibatide, which is a cyclic peptide derived from rattlesnake venom, and terifluban, a peptidomimetic inhibitor with the RGD sequence motif. This is also used for reversibly block the glycoprotein 2B or 3A receptor. Clinical applications of these drugs includes prevent restenosis after coronary angioplasty and are used in coronary syndrome such as unstable angina and in non-Q-wave acute myocardial infarction. Toxic effects of drugs blocking these receptors includes bleeding, and if used chronically, it is associated with thrombocytopenia. So bleeding and thrombocytopenia are the toxic effects. Dipyridamole and cilostazol, pharmacokinetic and mechanism of action. Before that, dipyridamole is a vasodilator and cilostazol is a phosphodiesterase inhibitor. Both of them prolong the platelet inhibiting action of intracellular CAMP by inhibiting phosphodiesterase enzymes that degrade cyclic nucleotide, including the CAMP, and inhibitor of platelet aggregation and cyclic guanosine monophosphate CGMP, which is a vasodilator. Clinical application or pharmacologic effects. Dipyridamole, this used as adjunct to warfarin in the prevention of thrombosis. It is also used in combination with aspirin for secondary prevention of ischemic stroke. Cilostazol, on the other hand, is used to treat intermittent claudication. This is a manifestation of peripheral arterial disease. Toxic effects of dipyridamole and cilostazol include headaches and palpitations. Miscellaneous, we have the danaparoid. Danaparoid, this is a heparin sulfate, chemically distinct from heparin. So danaparoid is available IV or SC or subcutaneous. Inhibition of thrombin, so they inhibit thrombin generation and thrombus formation that causes weakly enhanced antithrombin 3 and heparin cofactor 2. Danaparoid suppress the activation of factor 9, which in conjunction with factor 10 may lead to antithrombic effects. There is no evidence of hepatic metabolism regarding with danaparoid. Danaparoid unlikely undergoes cellular metabolism. Danaparoid is used for prophylaxis of postoperative deep venous thrombosis, or what we call as the DVT. Toxic effects includes respiratory depression, prostration, and twitching. Another miscellaneous is the protamine sulfate. This is a basic peptide obtained from fish sperm. This is in IV form. Protamine sulfate is a strong basic protein that binds with strong acidic heparin to produce a stable and inactive complex. Clinical application, so protamine sulfate is mainly used for heparin overdose, and it is also used to neutralize heparin given before surgery. It is used to treat hemorrhage as a result of severe heparin or low molecular weight heparin overdosage. So mainly for heparin overdosage. Toxic effects includes bradycardia, hypotension, and urticaria. Now let's move on to drugs used in bleeding disorders. Previously, we have tackled anticoagulant. Now, we will tackle drugs that will cause blood to coagulate. So, bleeding disorders. Inadequate blood clotting occurs as a result from these conditions: vitamin K deficiency, hemophilia, drug-induced conditions, and thrombocytopenia. Treatment of this includes vitamin K and antiplasmin drugs. We say vitamin K. So this is a fat soluble found primarily in leafy green vegetables. Vitamin K confers biologic activity upon prothrombin and factors 7, 9, and 10 by participating in their post-ribosomal modification. There are actually two natural forms exist in vitamin K. We have the vitamins K1 and K2. K1, vitamin K1 is a phytonadione, or it is found in food. Vitamin K2 is also known as the minaquinone or the minaquinone, that is found in human tissues and is synthesized in intestinal bacteria. This is Both of these require bile salts for absorption from the intestinal tract. Vitamin K1 increases the supply-demand of reduced vitamin K, which is required for synthesis of functional vitamin K-dependent clotting and anti-clotting factors. Next is the clinical application or pharmacologic effect of vitamin K. Vitamin K1 or the phytonadione is administered to all newborn to prevent the hemorrhagic disease of vitamin K deficiency, and is which is especially common in premature babies. So vitamin K deficiency is common in premature babies, and that is treated by vitamin K1 or phytonadione. Phytonadione is also used for reversal of excessive warfarin anti-clotting activity. Next is the toxic effects associated with vitamin K includes severe infusion reaction when given IV or fibrinolytic inhibitors. So back in anticoagulant, we tackled about fibrinolytic drugs. Now, for drugs that causes coagulation, we will tackle about fibrinolytic inhibitors. An example of that is the aminocaproic acid. Aminocaproic acid, or also known as with the abbreviation EACA. It is chemically similar to amino acid lysine and is a synthetic inhibitor of fibrinolysis. So aminocaproic acid is an inhibitor of fibrinolysis. It competitively inhibits plasminogen activation. It is rapidly absorbed orally and is cleared from the body by the kidney. Tranexamic acid, analog of aminocaproic acid, has same properties with aminocaproic acid. Clinical and toxic effects. Clinical application, toxic effects. So, aminocaproic acid is used as an adjunctive therapy in hemophilia. It is used as therapy for bleeding from fibrinolytic therapy, and used as prophylaxis for bleeding from intracranial aneurysms. Toxic effects of fibrinolytic inhibitors or aminocaproic acid includes intravascular thrombosis, hypotension, myopathy, abdominal discomfort, diarrhea, and nasal stuffiness. That is all. Thank you.